Pleasant morning, everyone. I am Loy McHugh, and I'll be presenting on the article entitled Diagnosis Dilemma in Vital Pulp Therapy. Treatment for the toothache is changing, especially in young, immature teeth. The following details will be discussed during the presentation. The title of the article, as well as the author of the article, will be mentioned and addressed. The journal in which the article is cited will also be stated, as well as the journal's impact factor. The date that the article is published will be mentioned, the major topic that the article addresses, as well as the type of article, the main purpose of the article, the key points presented in the article, and an assessment of the article will be done. Lastly, references and questions will also be mentioned or stated. Now, the article is entitled Diagnosis Dilemma in Vital Pulp Therapy. Treatment for the toothache is changing, especially in young, immature teeth. The author of the article is Dr. Joe H. Camp. The article is cited in the Pediatric Dentistry Journal, which is an official publication of the American Academy of Pediatric Dentistry. This journal has an impact factor of 65. Now, impact factors measure the importance of journals by calculating the number of times selected articles are cited over a number of years. So the higher the impact factor, the higher ranked the journal. So the Pediatric Dentistry Journal, which has an impact factor of 65 relative to the Nature Journal that is found in the United Kingdom and which has an impact factor of 1,159, is lesser ranked than the Nature Journal. The article was also published between May to June of 2008. The major topic that the article addresses is pulp therapy. Now, pulp therapy has the goal of preserving the integrity and health of the teeth as well as teeth supporting structures. Pulp therapy also seeks to maintain the vitality of pulpal tissue that is impacted by caries or trauma. Pulp therapy may be classified as direct, indirect, vital pulp therapy that would include indirect and direct pulp capping, pulpotomy, and pulpectomy, as well as non-vital therapy that would include apexification. And apexification induces a calcified barrier at the apex of a non-vital tooth with incomplete root formation. Now, the type of article being analyzed falls within the level of expert opinion on the evidence pyramid. Relevant studies on the main topic were identified and included in the article. Findings of such studies, such as those done by Borum and Treason and Sarkar et al., were interpreted and presented. Now, Sarkar et al. Studied reactions of mineral trioxide aggregate with dentine, and Borum and Treason found that 53% of subjects developed pulpal necrosis and 25% developed pulpal obliteration in a study entitled Sequelae of Trauma to Maxillary Incisors. So as these findings were interpreted and presented, the author of the article, who is also a dental clinician, then made deductions from these findings and formed conclusions related to the topic. Now, scientific studies which analyze the diagnosis of pulpal pathology in primary and permanent teeth with open apices are very few or limited. Many outcome studies are conducted on the basis of clinical signs and symptoms, and assumptions regarding pulpal status are made before treatment without histological or bacterial data to support preoperative diagnosis. Now, without histological examination being done, an accurate determination of the extent of pulpal inflammation is impossible, and thus there might be a deficit in knowledge as it relates to which pulpal procedures need to be done. So the author of this article decided to review the available literature and the current techniques of indirect pulp therapy, pulp capping, and pulpotomy for primary and permanent teeth with open apices, as well as the use of mineral trioxide aggregates as an apical barrier and composite for root strengthening. Now, the key points derived from the article analysis are as follows. Diagnosis of pulp vitality therapy differs in primary and immature permanent teeth and fully developed permanent teeth. Root formation in primary teeth is faster than that in the permanent dentition, due to the fact that primary teeth roots are shorter, and thus the development time for these roots would thus be quicker. Exfoliation of primary teeth also complicates root canal treatment. So during exfoliation, the apical resorption of the root occurs, and this shortens root length. This also complicates root length determination if root canal therapy is to be done. Furthermore, the proximity of succedaneous teeth to the primary teeth is vital. So the least likely treatment should be chosen that would least damage the permanent tooth that underlies the primary tooth. Furthermore, treatment should be oriented toward maintaining vitality to facilitate completion of root formation in immature permanent teeth. So, in diagnosing pulpal status in primary dentition, a dentist would obtain a thorough medical history from the patient, also the dental history of the patient, and the characteristics of the related pain that the patient presents with. Now, pain can be provoked or spontaneous. Provoked pain subsides after the stimulus is removed. It is also usually reversible and reflective of minor inflammatory changes. Spontaneous pain, on the other hand, occurs without stimulus or lingers after the causative factor is removed. It reflects tooth degradation, which extends to root canals. So after the history is elicited, a thorough clinical exam would be performed. Now, if during the exam signs of erythema or redness are seen, swelling, faulty restorations, severe dental caries, and draining abscesses are discovered, this would reflect pulpal involvement. Percussion sensitivity test is also valuable in diagnosing the pulpal status of primary teeth. After the clinical examination is done, appropriate radiographs would be obtained. Now, bite-wing radiographs are good to observe periapical pathology that relate to posterior teeth. Pathologic root and bone resorption on radiographs reflect advanced pulpal disease with involvement of periapical tissues. The tooth or teeth in question in these cases should be extracted. Radiographs will also show calcification of root canal chambers and oversized root canals that are indicative that the root has stopped forming, and as well as pulpal necrosis. Trauma, the signs of trauma rather, will also be shown on radiographs, and such signs would include root fractures, bone fractures, and displaced teeth. A tooth spontaneous pain history should be extracted or have pulpectomy performed on it. Now, 50% of primary teeth present with discoloration after being subjected to trauma. So, injured primary and permanent teeth with a dark gray discoloration are said to be are said to have pulpal necrosis. So, as seen in the image, there is a dark gray discoloration of the primary maxillary central incisor, and this is suggestive of pulpal necrosis. The dark gray discoloration is also seen in this permanent maxillary central incisor. Furthermore, primary and permanent teeth that present with a yellow discoloration generally have radiographic signs of pulpal canal calcification, and the yellow discoloration is seen here in the permanent maxillary central incisor, and this would suggest pulp space calcification, as was said before. In diagnosing pulpal status in immature permanent teeth, one would obtain a medical and dental history, including characteristics of the pain complaint. And I must say that diagnosing pulpal status in immature permanent teeth is quite similar to diagnosing pulpal status in primary teeth. So after obtaining the histories or the relevant histories from the patients, a clinical examination will be performed. Necessary radiographic examinations will be performed as well. Worthy of notation is that laser Doppler flowmetry and thermal testing with carbon dioxide have proven effective in testing pulp vitality in immature permanent teeth. Now, immature permanent teeth have the greatest potential to heal after caries or trauma. Radiographic and symptomatic assessment is the main diagnostic criteria. Furthermore, calcium hydroxide is now being replaced by a mineral trioxide aggregate and resin composite for the purpose of pulp therapy in immature permanent teeth. Now, the MTA, which is mineral trioxide aggregate, would act as an apical barrier, and it allows for continued root development. So it is used to treat open apex in pulpless teeth, right? And you'd have bonded composite techniques being performed with which would strengthen weak roots and prevent root fractures. Pulp therapy procedures spoken of would include pulp capping, which can be direct or indirect. And in indirect pulp capping, you'd have dental material being placed on the remaining porous dentine above the pulp. And direct pulp capping would involve treating the exposed vital pulp by sealing the pulpal wound with a dental material. Pulpotomy will be removing the coronal portion of the pulp and leaving the vital radicular portion of the pulp intact. So lastly, in assessing the article, it was found that the article had level 5 evidence, right, in assessing its clinical value as well as the quality of evidence that it presented. Furthermore, research regarding the article topic is ongoing as it is found within the level of expert opinion that was mentioned before, and it is quite evident that research is still ongoing as scientific studies, as it was mentioned in the article, that scientific studies which diagnose pulp pathology in both permanent immature teeth and primary teeth with open apices are few. So additional research needs to be carried out for more findings. Also, evidence presented is of low quality. Thus, if further research is done, that research is likely to have an important impact on the confidence in the estimate of the findings presented in this study. Now, as was spoken of before, the evidence pyramid that is shown in the pic here shows expert opinion being at the very bottom of the pyramid, right? So with this pyramid, different study designs are showed rather, and there's increased quality of evidence as the pyramid is ascended. So expert opinion would have very low quality evidence as it is at the bottom of the pyramid. Furthermore, I'd like to mention that expert opinion may be biased by the author's opinions or experiences, and this might have been a limitation in this study. Now, as it relates to clinical implications or applications of this study in clinical practice, despite the fact that evidence presented in the article is of low quality, such procedures and so forth could still be applied in clinical practice. Procedures of using thermal pulp testing for testing vitality, the pulp vitality are an example of what I spoke of. Now this is my reference, and it is now time for questions and also the end of my presentation. Thank you for listening.